All right, folks, welcome back to the blood chapter. This is going to be the ABO and RH blood typing system. So this is extremely important because what you're going to do in your life is you're going to be transfusing blood products into your patients. You'll go down to the lab and check out appropriate products. And there's a whole bunch of checks and balances, but both ends have to know what's going on because this is one event that could kill a patient. So the first thing is, I should tell you is there's lots of antigens on red blood cells. The A, B, O, and RH are simply two of the major antigen groups on red blood cells. There's actually lots of them. I'll just rattle off some. You don't have to look them up, or you can look them up if you want. There's Kid, Kel, Duffy, Lewis, Lutheran, I, MNS, P, and I'm sure I'm missing a bunch. I actually know I'm missing a bunch. I just don't remember all of them right now. So there's lots of antigens on red blood cells, and ABO and RH is just a major group. By the way, the A and the ABO, sometimes called the ABH, because the what we say is O blood type is actually the H antigen, is completely separate from the RH, which, by the way, is the D antigen. I know we always say A positive, B positive, AB positive, O positive, A negative, B negative, AB negative, O negative. I know we say that, but they're really separate antigens. It's just that they're the two major groups that we type and screen for. So we type for, and then we screen to see if the patient has any antibodies. So we talk about them together. So let's get started here. What happens is you have antigens on your red blood cells. These are chemical moieties sticking off your red blood cells that could elicit an immune response if given to the wrong patient. So that's what these antigens could do. All right. Now, if you're type A, you have the A antigen sticking off your red blood cell. And in addition, if you're type A, you make anti-B antibodies. These are anti-B antibodies. Now, that should make sense to you because you can't make anti-A antibodies. You would attack yourself and kill your own red blood cells. So if you're type A, you better not receive a unit of B blood because you will attack those cells, lyse them, and release all the potassium and other stuff into your body, and it would kill you. So when you're type A and you make anti-B antibodies, you can't receive any blood that has the B antigen on it. Okay, if you're type B, you have this B antigen on your red blood cells, and you make anti-A antibodies. So if you're type B, you can't receive any unit of blood that has the A antigen on it. Now, if you're type AB, you have the B antigen and the A antigen. You have both antigens on your red blood cells, and you don't make any antibody. Well, when I say you don't make any antibodies, you don't make anti-A or anti-B antibodies. I mean, this person makes antibodies. They make antibodies against streptococcus and staphylococcus and things like that, but they don't make any antibodies against the A antigen or the B antigen. All right? So does that mean that this person could receive any unit of blood? Yeah, that's what that means. Type AB, and more specifically type AB positive, which we'll get to, is the universal recipient. And we'll come back and talk more about this. But they can receive any unit of blood. Because if you give them an A unit of blood, well, they don't have an anti-A to attack that unit of blood. If they get a B unit of blood, they don't have an anti-B to attack that unit of blood. If they get an O unit of blood, well, first of all, not only do they not have an anti-O, but the O unit of blood has no surface antigens anyway. So AB is the universal recipient. All right. Type O has none of these antigens on its red blood cells. And when I say none of these, I mean none of these antigens in the A, B, H, and D system. So they might have other antigens like Kid, Cal, Duffy, Lutheran, Lewis, MNNS, these things, but we're talking about ABO and RH right now. So they don't have any of those antigens on their red blood cells. Well, we're not actually not talking about RH yet, but we will. Type O people make anti-Bs and anti-As. And they don't attack themselves because they don't have any antigens on their red blood cells. Now, that means that type O people can only receive type O blood. However, O packed red cells, O red blood cells, can be given to anybody. See, you could give this O blood cell to a type A person. They have anti-B antibody, but the O blood cell doesn't have a B antigen. You could give this O blood to a type B person. They have an anti-A antibody, but the O blood cell doesn't have any A antigens. You could give this O blood to an AB person. They don't make any antibodies. They're a universal recipient, but even if they did, the O blood cells doesn't have any antigens. So the type O person is called a universal donor. Now the reason why this works is because when you transfuse blood, you transfuse what we call packed red cells. It's a unit of blood. Here's the bag of blood with tubing sticking off of it that is filled with red cells. There's no plasma in it. So this unit of red blood cells doesn't have any plasma in it. So I don't have to worry about the antibodies that go along with what antigens are on these red blood cells. I only have to worry about the antigen on the red blood cells. The unit of blood that you transfuse into a patient is packed red cells. That's supposed to be right here it is, packed red cells. That's what you transfuse into a patient, packed red cells. Okay, so AB is the universal recipient and O is the universal donor. Now, not only do we have these ABO antigens on the red blood cells, but we also may or may not have D antigens on the red blood cells. And as it turns out, if you have these D antigens sticking off the red blood cell, then you are said to be Rh positive. If you don't have the D antigens, then you are said to be Rh negative. Now, unlike A, B, and O, if you are Rh negative, let's say this person's Rh negative, there's no D antigens. If you're Rh negative, you don't automatically make anti-D. See, if you're type A, you make anti-B. If you're type B, you make anti-A. If you're type O, you make anti-A and anti-B. But if you're Rh negative, you don't make anti-D unless exposed. So how would you get exposed to Rh positive blood? If you're Rh negative and you're exposed to Rh positive blood, that's a foreign antigen to you. Your body recognizes the D antigen as foreign and you make antibodies against it. So if you're Rh negative, you don't make anti-D unless you're exposed to Rh positive blood. And there's a couple ways to be exposed. You could be exposed by transfusion, or you could be exposed during pregnancy. And we'll talk more about this. But I want to go back through and say this. Because of this exposure to Rh positive blood by Rh negative people, yielding an anti-D antibody, you can't give Rh positive blood to an Rh negative person. But you can give Rh negative blood to an Rh positive person. See, giving Rh negative blood to an Rh positive person means you're giving blood cells to them that don't have the D antigen, and they do. Who cares? They're never going to build the anti-D anyway, and even if they did, well, if they did, they'd attack themselves. but they wouldn't be attacking the donor unit, which just lacks the D antigen. So you can give Rh negative blood to an Rh positive person, but you can't give Rh positive blood to an Rh negative person because they'll build the anti-D antibody and attack the unit of blood. So really, who the universal recipient is AB positive, because the universal recipient being AB positive means they can get Rh positive and Rh negative blood. So the universal recipient can get A positive and A negative. They can get B positive and B negative. They can get AB positive and AB negative. They can get O positive and O negative. But if the AB person, the universal recipient person, was AB negative, they would only be able to they would only be able to receive these negative units of blood. So you see, the universal recipient is really AB positive, who can receive all of these units of blood, whereas an AB negative person can only receive half of them. All right. Now, the universal donor, type O. The universal donor is really O negative, because if it was O positive, you couldn't give it to A negative, B negative, or AB negative people. But the universal donor, being O negative, means that you can give these to an A positive or an A negative person. You can give it to a B positive or a B negative person. You can give it to an AB positive or an AB negative person. You can give it to an O positive or an O negative person, because you can give negative blood to positive people. All right. Please let me know in lab if you don't get this, because this happens to be on your next test and it's on your final, because this is very, very important that you get this. What happens is you'll go to the lab to check out a unit of blood, and you and the lab folks will go through a procedure of eliminating error. But it's important that you both know what's going on, both the nurse and the medical technologist. All right, this is how it shows just a couple things here. First of all, this is how we test for ABO and RH. And this is also what happens that makes it so dangerous to transfuse the wrong unit of blood. So first of all, how do we test for ABO and RH? What we do is we buy this antisera from the store. We buy it. And we take the patient's red blood cells. These are patient's red cells. And we mix them together and we look for agglutination. See, if I bought this antisera, let me go back and see what the blue is. I'll stay consistent. The blue is B. If we buy this anti-B antisera, well, don't I know it's anti-B antibody? Yeah, because I bought it. I mean, when you buy a hammer, you know it's a hammer. You don't think it's a screwdriver. So I buy this anti-B antisera from the store. And now this is not Walmart, of course, but it's a scientific store. And if I mix this anti-B antisera with a patient's cells, and they agglutinate, which I can see because it clumps, then I know the patient has the B antigen. So that's how I test. But this picture also shows me something else. It also shows me why it's important to transfuse the correct unit of blood. Because if I were to give packed red cells, this is not patient RBCs anymore. These are packed red cells, a unit of blood ready to be transfused. If I were to give them to a patient that had the antibodies against the unit of blood, so these are no longer this is no longer antisera bought from the store. This is the patient's body. This is the patient's body. If I were to give the packed red cells to a patient that had antibodies against them, the antibodies would bind and lyse the cells. This is called hemolysis. And this is really bad because what happened, one of the quickest things that kills you is this. Your potassium goes way up. You get hyperkalemia because there's potassium inside the red blood cells. So you have all that potassium now floating around, and that makes your heart stop beating. So that's probably there's a lot of other things that happen as well. I mean, first of all, it's not good to have these cell fragments floating around. That's one thing, but probably the thing that kills you quickest is the hyperkalemia. So you got to transfuse the correct unit of blood or that will happen. And that's called a transfusion reaction, by the way. If this happens, it's called a transfusion reaction. All right, this is the collage showing you type A, type B, type AB, type O. It shows you the glutination which happens between antisera and the antigens. By the way, antibodies are also called agglutinins, and antigens are also called agglutinogens. And you need to know that because those words are used interchangeably. Agglutinin and antibody is used interchangeably, and agglutinogen and antigen is used interchangeably. All right, this is what it looks like when we're testing. See, what I did is this blue stuff right here is antisera. It's anti-A antisera that I bought from a store. That's what it is. And this stuff right here, believe it or not, is patient's red blood cells. Now, that's clumping. So what does that tell me? It tells me this patient has the A antigen. Does the patient have the B antigen? Well, I don't know from this reaction, but I can take another test tube or another well on a plate, and I can add anti-B antisera to it and the patient's cells. Do I see any clumping? No. There is no B antigen. Well, I know this patient is A, and I know the patient is not B. So the patient's not AB, but the patient's A. But I don't know what the RH is yet. I don't know if the patient is A positive or A negative. So I take anti-D antisera, and I mix it with the patient's cells. And this is clumping. You're going to say, this is not as powerful clumping as that is right here. And I'll agree with you. We actually grade clumping by 1+, 2+, 3+. This is 3+ clumping. This is, believe it or not, 2+. It gets weaker. Like this is weaker. This is 1+. So this is 2+ clumping, which means the patient has the D antigen. That makes the patient A positive. This is a case where the patient doesn't have the D antigen. And by the way, doesn't have the A antigen. There's no clumping here. It's all, doesn't look like this. See, it doesn't look like that. So the patient doesn't have the A antigen. The patient doesn't have the B antigen. Whoops, God. The patient doesn't have the B antigen. So there's no A, there's no B, there's no D. O negative patient. This right here, this row is a patient that has the A antigen, the B antigen, and the D antigen, AB positive. This is how we test it. Now I say that to you, and this is an old way of testing it. There's actually new ways now called gel technology. Pretty quick, more sensitive, picks up some of the nuances that can be problems that we won't talk about, but if you're going to be a medical technologist, you'll learn in detail. So this is pretty cool. This is how we test for ABO and RH blood types. Please don't memorize any of these. Actually, I will have you memorize one thing. O is the most common blood type in the United States. A is the second, B is the third, and AB is the fourth. This is greater than 40%. This is less than 10%. I don't remember the exact numbers. 85% of the people are RH positive, and 15% are RH negative. I would like you to memorize that. What this table tells you is probably what I just said, and I'll find it for you. But it also breaks it down by ethnic groups. Because the frequency or percentages of different ABO and RH antigens differs among ethnic groups. So look at O is the most common, 46%. A is the second most common, 40%. So O and A make up 86% of the U.S. population. B is less frequent, 10%, and AB is 4%. All right, now 85% of the people are RH positive. 15% are Rh negative. I'm not going to have you memorize subcategories among ethnic groups at all. I'm just giving you the U.S. average. All right. Why does the American Red Cross want O blood so often? Because it's a universal donor. Because if you run out of O blood, that's the blood that can be given to anybody, even untyped. That's why they always want O blood.
Type 2 hypersensitivities involve interactions of antibodies and surface antigens of cells, followed by complement-assisted lysis of these cells. A typical example is mismatched blood transfusions. There are 4 different blood groups based on types of antigens on the surfaces of the red blood cells. People who are type A have A antigens, and those who are type B have B antigens on the surfaces of their red blood cells. Persons who are type AB have both A and B antigens, and those who are type O have neither A nor B antigens. The serum of people with type A blood contains antibodies against type B antigens, and the serum of people with type B blood contains antibodies against type A antigens. Type AB serum contains neither antibody, and O serum contains antibodies against both A and B antigens. If blood from a person who is type B is transfused into a person who is type A, antibodies present in the type A blood react with the surface antigens on the incoming red blood cells. This leads to complement fixation and lysis of these cells. If blood from a person who is type A is transfused into a person who is type B, antibodies present in the type B blood react with the surface antigens on the incoming red blood cells. This also leads to complement fixation and cell lysis. Persons who are type O lack A and B antigens on the surfaces of their red blood cells and are therefore universal donors. Persons with type AB blood lack antibodies against A or B antigens and are therefore universal recipients.
Okay, now this is going to talk about the RH the next couple slides. Remember I told you that RH negative people don't make anti-D unless they're exposed. So there's no anti-D in Rh negative people as they're walking around the street unless exposed to Rh. And then I said to you there's a couple ways to be exposed to Rh, and one was transfusion, improper transfusion I should say, and one was pregnancy. So we're going to talk about what happens if the mom is Rh negative. And by the way, this only is with Rh negative moms, because if the mom's Rh positive, she's never going to make anti-D antibody because she'd attack herself. But Rh negative moms, if they're exposed to the D antigen, will make an anti-D antibody. Well, how could they be exposed? The baby could be Rh positive. Well, now I'm telling you that there's mixing of the mom and baby's blood. And the answer to that is yes, there's slight mixing of the baby's blood into the mother. There is slight mixing. So here's the fetal blood supply right here. You can see the Rh positive cells in the baby. And the fetal blood supply travels through the umbilical artery and vein, capillaries in this case. And here's the mom's blood supply. And what happens is mom gives oxygen to the baby. And waste products from the baby enter the mom. So the baby's kidneys, although they might be functioning, they're not getting rid of waste products. So the waste products go out through the mom's circulation. Well, every now and again, one of these Rh positive cells slips through there. That can happen. It doesn't happen a lot, but some baby cells get into mother circulation. We do a stain for this in the lab, and it's called the Kleihauer-Becke stain. Let me spell it for you. It's called the Kleihauer-Bet key. And we actually count fetal cells in the mom's circulation. You might see one in 1,000, one baby cell in 1,000 mom cells. And you actually count 2,000 cells. You might see one baby cell in 2,000 mom cells. You might not see any. But it's not abnormal to have a little bit of baby cells in the mom's circulation. Now, what happens when that happens? Well, if the mom's if the mom's Rh negative and the mom sees the Rh positive cells, she makes the anti-D antibody. Now, as it turns out, this anti-D antibody right here is small enough to cross the placenta. That means that antibody can now enter the baby's blood and attack the baby cells and lyse them. And if the anti-D crosses the placenta and binds the baby cells, we get this disease right here. And it's called hemolytic disease of the newborn. And that's because the anti-D is lysing the baby's red blood cells. It used to be called erythroblastosis fetalis. This is the old name for it. All right, so that's how that's working. Look at this. 20% of Rh negative mothers who carry Rh positive children make anti-D. That's what becoming sensitized means. That's supposed to be an antibody. My drawing's horrible. 20%. And you're going to say that's only 20%. That's quite a bit. And since it can lead to the death of the fetus, that's not good. By the way, you keep reading, it says 20% of Rh negative mothers become sensitized within 6 months. It's the number that becomes sensitized overall is going to be much, much higher. Now, here's the deal. Probably the mom wouldn't hurt her first baby. Because you see, the first time an Rh negative mom has an Rh positive baby, it takes months to make a lot of those antibodies that I just circled. It takes months. So by the time the mom makes enough of those antibodies to really cross the placenta and hurt the baby is being born. But mom's been sensitized. So now if she gets pregnant with her second or subsequent Rh positive baby, her body will kill that baby. And if you think back in your family history or a friend's family history, and you had a great-grandmother who had 9 kids and she lost 3, she had 9 living kids, she had 12 pregnancies and lost 3 of them. Well, sometimes that's this hemolytic disease of the newborn that wasn't understood or treated back then. But we treat this today. We prophylactically treat it. So here's the mom's antibodies crossing the placenta, attacking the baby's cells. Here's what we do. Here's a baby cell with the D antigen. Let me just make it a D. Here's the baby cell with the D antigen sticking off. And let's say this is the cell that's going to enter the mom's circulation. We give a shot of what we call RhoGAM. And it stands for Rh gamma globulin. And if you remember from the first lecture in this chapter, gamma globulins are antibodies. So this is an anti-D antibody. Rh gamma globulin is an anti-D antibody. But it's a shot that I gave the mom. All right? And we actually happen to give the shot for a type of antibody that doesn't cross the placenta. RhoGAM does not cross the placenta. So it's not like we're giving a shot of RhoGAM that'll cross the placenta and hurt the baby. It won't. But here's what RhoGAM does. RhoGAM binds all these Ds of the baby cells that entered mom's circulation. Remember, we gave the shot to the mom. And because RhoGAM covers up all those Ds, the mom's immune system doesn't see them. And therefore, she doesn't mount an immune response against the D antigen. She doesn't make anti-D antibodies. So she's not sensitized. RhoGAM prevents sensitization, and now the mom can have more Rh positive babies. So this is RhoGAM, and all Rh negative moms get a shot of RhoGAM. They get it prophylactically at about 26 weeks. So 20, I think it's in here someplace. Right here. They give it prophylactically between 26 and 28 weeks, and then they get it again at childbirth. So at parturition or at childbirth. So moms get RhoGAM shots if the mom's Rh negative. That's it for that. Please ask me questions in lab if any part of that is not understood perfectly, because ABO and Rh compatibility is extremely important, and it's going to be on the next test plus the final. All right, I'll talk to you later.